How do you choose which CAR T cell to use?
I think this is a question we get a lot. I think the fundamental question is if a patient needs CAR T, they should get whatever is available. There are real issues right now with availability of slots, manufacturing availability, things like that. So if they need a CAR T, they should get whichever one is available. I think if there's a choice, I think a lot of people would choose cilta-cel, or Carvykti is the commercial name for it, given the very long progression-free survival that we've seen on that trial. I think it's hard to compare different trials. The patient populations are different. The way they were used is a little bit different. So we can't say for sure that cilta-cel is better than ide-cel, but I think given the data we have, it'd be reasonable to choose that. I think the last consideration to make is whether or not there are other factors. So patients often have other comorbidities, so other diseases, diabetes, high blood pressure, heart disease, kidney disease, and that can sometimes also play a role in which product to choose. So we've had a fair bit of experience treating patients, for instance, who are in hemodialysis from kidney disease using ide-cel in that scenario. And so, it may be that one or the other product might be a little bit less toxic or less dangerous with particular, comorbid conditions.
Where can I learn more about CAR T treatment?
Studies have shown that educated and empowered patients often have better outcomes. HealthTree University is the first and only free, comprehensive curriculum for patients and caregivers. Create a free account to gain exclusive access, where you can watch our newest unreleased videos, easily explore topics through our organized courses, and assess your knowledge with interactive quizzes. Visit HealthTree University and become an empowered patient today.
How do you choose which CAR T cell to use?
So it's certainly great that we're living in a time where we have 2 FDA-approved CAR T products for patients with relapsed refractory multiple myeloma. We even have a BCMA targeting bispecific that was recently approved. So it's nice to have these options. I do get asked all the time in the clinic from the patients, which CAR T product, what about CAR T versus bispecific, how to choose. It's not an easy decision. I think it's very complicated discussion that should be had between the patient and his or her myeloma doctor. Because none of these, the 2 CAR T products are not compared head to head in this, what we call randomized control clinical trial. That's the most rigorous way to say, which CAR T product worked better. Certainly CAR T versus bispecific, have not been compared. And the treatment logistics, involves oftentimes for patients, depending on where they live, travel to a specialized center to get the treatment. It's not an off-the-shelf drug that you can decide, hey, if I qualify, can I just get this in the next few days or within a week? And this often takes months of planning, additional management while CAR T is being made. So there's a lot of details to go through for the patient to decide, is that something that is feasible for them to do? Are there resources to help them get through the treatment? What are the side effects? These side effects often are very different from the type of drug-based treatment they've had before, or even stem cell transplant if they've had before. So they need to understand, the different side effect profile. So it's a very personalized decision, and for the doctor, in talking with the patient, is to take into consideration, does the patient have other, health conditions that might make them at a little bit higher risk of going into CAR T or not? And, what has the patient had treatment-wise before or most recently? So there's no one fixed answer for all patients. It's very much an individualized decision. And I would say up until very recently, and despite having those 2 products being FDA approved, manufacturing access has been extremely limited when it went into availability in the practice. And so that makes it more challenging. All centers wanted to be able to have this option for patients, but they don't have enough manufacturing slots for all patients who potentially could get the treatment to get them. And so there were long waiting lists, which also get into selection consideration. You know, some patients can't wait that long for the CAR T. Now, we are seeing that some of these challenges for manufacturing access are slowly improving. And so we're seeing a little bit more slot access. And so literally it's, you know, last month versus today, the situation could be very different. And that does factor into my conversation with the patient in terms of, you know, could I get a manufacturing slot and for which CAR T product? Is it literally in the coming week or are we talking about in the coming month? And those have to be factored in with what's the patient's current myeloma status, how quickly is their myeloma progressing on the current treatment to, you know, come together with a plan that, you know, it's feasible for the patient that I also think clinically is most likely to have the patient be able to get to for it to work.
There have not been any head-to-head comparisons on ide-cel or Abecma and Carvykti, but what we have seen is what's available on the clinical trials. So as we know, ide-cel targets the myeloma cells in one BCMA area and Carvykti in two BCMA areas, and we've seen the response rate for Abecma to be 73%, for Carvykti to be about 98%. How do we choose? So we choose a bit based on disease burden, toxicity, and just the patient's, how are they doing prior to CAR T? So commonly what we have done at Moffitt, and there's no rules that are set in stone for this, but generally if somebody is older, like above 75 and may have illnesses or comorbidities, for example, renal dysfunction or kidney problems, or they may be on dialysis, or they may be, let's say, wheelchair bound because they have a myeloma lesion, we may consider ide-cel or Abecma. Also, if somebody has neurologic history, or so like history of seizures or epilepsy or some kind of traumatic injury, we commonly try to be very careful, generally prefer Abecma rather than cilta-cel or Carvykti for those patients because there is an increased risk for developing what we call delayed neurologic toxicity in the form of neurocognitive disorders like Parkinson's disease, for example. So we try to be a bit more selective. So generally the younger, fitter patients, potentially Carvykti, the older, less fit patients, maybe Abecma just for tolerability reasons. Again, there's a no shoe fit all, but these are just some general guidelines. Now, with that being said, we do have a consortium of 15 that is growing, almost 18 centers, including some of the major centers, Moffitt, MD Anderson, Stanford, City of Hope, Dana-Farber, Mayo Clinic, where we are actually looking at patients treated with commercial products for ide-cel. And we've submitted some data for cilta-cel or Carvykti that hopefully we will be presenting at ASCO. For ide-cel patients or Abecma, I can tell you that our patients in the real world setting or receiving commercial product actually did just as well as what the clinical trial patients did. The response rate looked really good and toxicity looked just as it did on clinical trial. So, but the majority of those patients would have been trial ineligible. So like 75% of our patients had low blood counts, or they had had a prior BCMA agent, or they had renal insufficiency or kidney problems. Regardless of these things, Abecma seemed to do just as well in patients who would have been trial ineligible otherwise. Regarding Carvykti, we just looked at that data. It's currently embargoed, but a lot should have some very interesting and hopefully helpful information in the coming months at ASCO.
So we have a number of different CAR T products. We have Abecma or ide-cel. We have Carvykti or cilta-cel. So these are our two standard of care products, but there's also a lot of different CAR T products that are in clinical development and in various phases of clinical trials. So the question of, which CAR T do you go to? Right now, it's really about availability. So if you have an opportunity to go on clinical trial, we always promote clinical trials. And it allows us an opportunity to explore different types of CAR T constructs, different targets, different types of CAR T. In addition, when we look at the outside of the clinical trial space and standard of care space, we say really what's available. The availability of ide-cel and cilta-cel are really limited at this point, and it's only in academic centers. However, not every academic center is able to get those products for our patients. So there's allocations of these different drugs. And so a lot of the times right now, it really comes down to what is available, okay? Ide-cel does not seem to be performing as well as cilta-cel. Both are very effective in patients with heavily pretreated disease. Both are very good products. If you're in a position where you're eligible for CAR T, either will be a good choice for you.
The decision about CAR T is very complex. First off, I love the breakdown of, hey, can I get on a clinical trial related to CAR T, or is there a standard of care CAR T available? Right now, the bandwidth for CAR Ts is very low across the nation. So many times a standard of care CAR T is not available. And if there is a clinical trial spot available and the clinical trial is amenable, looks to have a small amount of suffering for access to a treatment you wouldn't normally get, I think you should sign up for it. And so most CAR T clinical trials are pretty simple trials right now. They're looking for a particular type of patient. You meet that eligibility, and there's not a lot of bells and whistles to begin the treatment. So if you have a clinical trial with CAR T, I would try to sign up for it, because right now the bandwidth for standard of care CAR Ts are not available. But let's say clinical trials are out of the picture. Now we're just thinking about standard of care CAR Ts. Well, there's two products available. There's Abecma and Carvykti. And of those two, which should you choose? If you could choose which one you can get. If that were the case, most people would choose Carvykti, as that the majority of the patients treated thus far have a longer period of disease control after receiving the Carvykti cells than they did after the Abecma cells. Yes, there may be more neurologic side effects or so-called neurotoxicity with Carvykti, but these are patients who've had multiple relapses. So their myeloma is difficult to control, and their lifespan is primarily dedicated or influenced by the amount of myeloma control. So if they can get a longer period of myeloma control, that's what makes Carvykti more appealing based on the data we have to date.
Should a patient wait for a Carvykti spot or go with Abecma if there is a spot available?
At this spot, for most patients who are relapse refractory and they've had 3 prior lines of therapy at least, the options usually are not pretty. You're dealing with Blenrep, where you have significant eye side effects. You're dealing with selinexor, where you have significant gastrointestinal and constitutional side effects, nausea, vomiting, fatigue. And then you have CAR Ts. These are all about the same time. And if you look at them, well, Blenrep could be great because it's just thrombocytopenia if you don't have the eye side effects. And selinexor, there's a very small proportion of patients that have a great response to selinexor and have very few side effects, but that's the minority. And then there's CAR T that basically shines here and has an excellent response rate and is a one-time therapy. So if you're at this spot, relapse refractory myeloma, and these are your choices, and you have Abecma there but no other CAR T and no other bispecific, I would absolutely take it.